Moderator Dr. Jyoti Pathania, presented by Dr. Kamal Prakash Sharma. Anesthetic implications of Pheochromocytoma and Cushing syndrome and Addison's disease. Moderator Dr. Jyoti Pathania. Presented by Dr. Kamal Prakash Sharma. Pheochromocytoma 0.01 to 0.1% of HTN population, M equals F. Found in 0.5% of those screened. M equals F. 3rd to 5th decades of life. Rare. Investigate only if clinically suspicion. Signs or symptoms. Severe HTN, HTN crisis. Refractory HTN, greater than 3 drugs. HTN present at age less than 20 or greater than 50. Adrenal lesion found on imaging, X. Incidentaloma. Pheo, signs and symptoms. The 5 Ps, the classical triad. Pressure, HTN 90%. Pain, headache 80%. Perspiration 71%. Palpitation 64%. Pallor 42%. Paroxysms, the 6th P. The classical triad. Pain, headache, perspiration, palpitations. Lack of all 3 virtually excluded diagnosis of Pheo in a series of greater than 21,000 patients. Pheo, paroxysms, spells. 10 to 60 minutes duration. Frequency, daily to monthly. Spontaneous. Precipitated. Diagnostic procedures, IA contrast, IV is okay. Drugs, opioids, unopposed blockade, anesthesia induction, histamine, ACTH, glucagon, metoclopramide. Strenuous exercise, movement that increases intra-abdo pressure, lifting, straining. Pheo, hypotension. Hypotension, orthostatic/paroxysmal, occurs in many patients. Mechanisms. ICF contraction. Loss of postural reflexes due to prolonged catecholamine stimulation. Tumor release of adrenomedullin, vasodilatory neuropeptide. Pheo, signs and symptoms. NV, abdo pain, severe constipation, megacolon. Chest pains. Anxiety. Angina/me with normal coronaries. Catecholamine-induced, myocardial oxygen consumption or coronary vasospasm. CHF. HTN hypertrophic cardiomyopathy, diastolic dyspnea. Catechol-induced dilated cardiomyopathy, systolic dyspnea. Cardiac dysrhythmia and conduction defects. Pheo, signs, metabolic. Hypercalcemia. Associated Men2-HPT. PTHRP secretion by Pheo. Mild glucose intolerance. Lipolysis. Weight loss. Ketosis greater than VLDL synthesis, TG. Pheo, rule of 10% extraadrenal 10% occur in children. 10% familial. 10% bilateral or multiple, more if familial. 10% recur, more if extraadrenal. 10% malignant. 10% discovered incidentally. Catecholamines metabolites tyrosine L-dopa dopamine home of vanillic acid. TH. MAO, COMT. Tyrosine. L-dopa. Dopamine. Home of vanillic acid. HVA. DBH. COMT. Norepinephrine. Normetanephrine. PNMT. MAO. Epinephrine. COMT. Metaneprine. MAO. Vanillimandelic acid. VMA, familial Pheo Men2A 50% Pheo, usually bilateral, MTC, HPT Men2B. 50% Pheo, usually bilateral, MTC, mucosal neuroma, marfanoid habitus. Von Hippel-Landau. 50% Pheo, usually bilat, retinoblastoma, cerebellar hemangioma, nephroma, renal/pancreas cysts. NF1, von Recklinghausen's. 2% Pheo, 50% of NF1 and HTN. Café au lait spots, neurofibroma, optic glaucoma. Familial paraganglioma. Familial pheo and eyelid cell tumor. Other, tuberous sclerosis, Sturge-Weber, ataxia telangiectasia, Carney's triad, pheo, gastric leiomyoma, pulmochondroma. 24 hours urine collection. 24 hours urine collection. Creatinine, catecholamines, metanephrines, vanillimandelic acid, VMA, +/dopamine. HPLC with electrochemical detection or mass spect. Positive results, greater than 2 to 3-fold elevation. 24 hours catechals greater than 2-fold elevation. ULN for total catechals 591 to 819 mol/d. 24 hours total metanephrines greater than 1.2 micrograms/d, 6.5 micromoles/d. 24 hours UVMA greater than 3-fold elevation. ULN 35 micromoles/d for most assays. Sensitivity increased if 24 hours urine collection begun at onset of a paroxysm. Plasma catecholamines. Drawn with patient fasting, supine, with an indwelling catheter in place greater than 30 minutes. Plasma total catechals greater than 2000 pg per milliliter. Sen 85%, spec 80%. False positives, same as for 24 hours urine testing, also with diuretics, smoking. CRF and ESRD. Oliguric to anuric 24 hours urines inaccurate. Plasma epinephrine best test for pheo in ESRD. Plasma norpi and metanephrines falsely elevated in ESRD. Plasma metanephrines not postural dependent, can draw normally. Secreted continuously by pheo. Sen 99%, spec 89%. False positive, acetaminophen. Assay not readily available in Canada. Suppression/stimulation testing. Clonidine suppression may precipitate hypertensive shock. Unlike normals, pheo patients won't suppress their plasma norpi with clonidine. Glucagon stimulation may precipitate hypertensive crisis. Pheo patients, but not normals, will have a greater than 3x increase in plasma norpi with glucagon. Localization, imaging. CT abdomen. Adrenal pheo Sen 93 to 100%. Extraadrenal pheo Sen 90%. MRI. Greater than Sen than CT for extraadrenal pheo. MIBG scan. Sen 77 to 90%, spec 95 to 100%. 111 indium pentriotide. Some pheo have somatostatin receptors. PET. 18F-fluorodeoxyglucose, FDG. 6,18F-fluorodopamine, pheo management. Prior to 1951, reported mortality for excision of pheochromocytoma 24 to 50%. HTN crisis, arrhythmia, ME, stroke. Hypertensive shock. Currently, mortality, 0 to 2.7%. Preoperative preparation, blockade. New anesthetic techniques. Anesthetic agents. Intraoperative monitoring, arterial line, EKG monitor, CVP line, Swan-Ganz. Experienced and coordinated team. Endocrinologist, anesthesiologist, and surgeon. Preoperative workup CBC, electrolytes, creatinine, INR/PTTFBS. CA, if one of men's syndrome is suspected. CXR. EKG. Echo, RO dilated CMY 2 degrees catechals. Pre-op preparation regimens. Combined plus blockade. Phenoxybenzamine. Selective 1 blocker, X. Prazosin. Propranolol. Metyrosine. Calcium channel blocker, CCB. Nicardipine. No randomized clinical trials to compare various regimens. Pre-op plus blockade. Start at least 10-14 g pre-op phenoxybenzamine. Allows sufficient time for ec-free expansion. Phenoxybenzamine. Drug of choice, non-competitive and long-acting. Covalently binds receptors, 1 greater than 2. Start 10 mg per bid. Increase Q2D by 10 mg/d. Maintenance 40 to 80 mg/d, some need more than 200 mg/d. Endpoints indicating adequate pre-op preparation are: 1. Increase until BP control and no more paroxysms. No in-hospital BP higher than 165/90 should be evident for 48 hours before surgery. 2. FBS will return to normal. 3. PCV will decline to around 40 to 43%. 4. Orthostatic hypotension should be present, but BP on standing mg/d should not be lower than 80/45 of a millimeter of Hg. 5. ECG must be free of St changes that are not permanent. 6. No greater than 1 premature ventricular contraction should occur every 5 minutes. Pre-op plus blockade. Phenoxybenzamine, COMTED, selective 1 blockers. Side effect: orthostasis with dosage required to normalized seated BP, reflex tachycardia. Drawback: periop hypotension/shock unlikely to respond to pressor agent. Selective 1 blockers: prazosin, terazosin, doxazosin. Some experience with prazosin for pre-op prep. Not routinely used as incomplete blockade. Less orthostasis and reflex tachycardia than phenoxybenzamine. Used more for long-term RX, inoperable or malignant pre-op plus blockade. Used to control reflex tachycardia and prophylaxis against arrhythmia during surgery. Start only after effective blockade, may PPTHTN. If suspect CHF/dilated CMY, start low dose. Propranolol most studied in PhEO-PrEP. Start 10 mg per bid. Increase to control HR, pre-op, plus blockade if BP still not controlled despite plus blockade. Add prazosin to phenoxybenzamine. Add CCB, ACE-I. Avoid Ditox as already ICF contracted. Tyrosine, pre-op, plus blockade. Medications given on morning of surgery. Periop HTN. 1,4-phentylamine. Short-acting non-selective blocker. 2,4-nitroprusside, NTP. Periop arrhythmia, 4-esmolol. Periop hypertension, 4-crystalloid plus/colloid. Pheo, Rx of HTN crisis 4-phentylamine 4-NTP 4-esmolol. Forlobetalol, combined plus blocker. Pre-op, tyrosine synthetic inhibitor of tyrosine hydroxylase, TH. L-dopa. Dopamine. Synthetic inhibitor of tyrosine hydroxylase, TH. Start 250 mg max 1 gram ct. SEs, sedation, extrapyramidal, diarrhea, anxiety, renal/cholelithiasis, galactorrhea NV. Alone may insufficiently control BP and reported HTN crises during operation. Restrict use to inoperable/malignant pheochromocytoma or as adjunct to plus blockade or other preoperative prep. DPH. Norepinephrine. PNMT. Epinephrine. Pre-op, CCB. Nicardipine block norepinephrine-mediated CA uptake intravascular smooth muscles. Started per 24 hours to few weeks pre-op to control BP and allow ICF restoration. After intubation for nicardipine, start 2.5 micrograms/kg per minute. For nicardipine adjusted to SPP. Stopped prior to ligation of tumor venous drainage. Tachycardia Rx with concurrent 4-esmolol. Advantage: periop hypotension may still respond to pressor agents as opposed to those patients who are completely blocked. Perioperative at midnight before for overnight for saline. 2 large bore IV lines should be secured. Arterial line. CVP line. Routine pulse oximetry, ECO2, EKG, temperature probe. Known CHF, consider Swan Gans. Regardless of pre-op medications. Have ready, 4 phentylamine, 4 NTP, 4 esmolol. RX hypotension with cristoid plus/colloid first. Aim for CVP12 or wedge 15. Inotropes may not work. Intraoperative considerations. 3 critical phases of tumor resection are: 1. Induction and intubation. 2. Surgical manipulation. 3. After ligation of the tumor's venous drainage. Induction and intubation. Etomidate, thiopental, and propofol can all be used to initiate anesthesia. Increase anesthetic depth by bag mask ventilation with volatile anesthetic. Lidocaine 1 to 2 mg/kg 1 minute prior to induction. Narcotics. Fast-acting antihypertensive readily available. Anesthetic choice. N/sevo/isoflurane, don't sensitize myocardium to catecholamines. Halothane, may sensitize heart arrhythmia. Maintenance during surgery. Anesthesia is maintained with gases and narcotics. VAR easy to titrate, can help with HTN, 1.5 to 2 Mac. PT should be kept normovolemic. Blood glucose monitoring. Hypertensive episodes managed by deepening volatile anesthetic level. Nitroprusside at 0.5 to 10 micrograms/kg/m via infusion. Phentylamine mixed at 10 mg/100 ml D5 Watt tachycardia can occur, small dose of esmolol/propranolol can treat it. Maintenance during surgery. Propranolol/short-acting beta-blocker esmolol may be required during this period if there is persistent tachycardia/premature ventricular contractions. Ligation of the tumor's venous drainage. Circulating catecholamine causing hypotension. After ligation of all venous drainage, arterial pressure commonly declines RTCO, SVR. Treatment. VA. IVF. Phenylephrine or norepinephrine, post-op. 1. Invasive lines should stay intact. PT still at risk for liable BP. 2. PT susceptible to hypotension that is refractory to fluid volume expansion. 3. Still have high volumes of circulating catecholamine despite tumor resection. 4. Catecholamine levels normalize after several days. 75% of PET's BP returns to normal after 10 days. 5. Prone to hypoglycemia. Secondary to suppression of beta cell function disappears after the tumor is removed. Pheo and pregnancy diagnosis with 24 hours urine collections and MRI. No stimulation tests, no MAB if pregnant. First and second trimester, less than 24 weeks. Phenoxybenzamine plus blocker prep. Resect tumor laparoscopically. Third trimester. When fetus large enough, caesarean section followed by tumor resection. Addison's disease A. Clinical features. Addison's disease is characterized by decreased or absent glucocorticoid secretion, usually combined with mineralocorticoid insufficiency. It can be primary or secondary and may present as an acute, chronic, or acute-on-chronic illness. The most common cause is autoimmune. A. Clinical features. Postural hypotension and dizziness. Hypokalemia and hyponatremia. Hypoglycemia. Nausea, vomiting, diarrhea, and weight loss. Decreased body hair. Pigmentation especially in areas exposed to the sun. Can be associated with pernicious anemia, myasthenia gravis, and vitiligo. May not be clinically obvious until a significant stress occurs. B. Investigations. 1. Low serum glucose. 2. Low Na+, raised K+ and urea. 3. Low bicarbonates, nomocytic anemia. 4. Plasma ACT measure simultaneously with plasma cortisol at 08:00h. 4. Plasma ACT measure simultaneously with plasma cortisol at 08:00h. Even if cortisol is normal, the ACT will be elevated. 5. Plasma renin activity and aldosterone. Plasma renin activity is usually low with a low aldosterone. 6. Short synecthin cosintropin stimulation test. 250 micrograms of synecthin dissolved in 1 milliliter of sterile water is given I/5 or 1/m. Serum cortisol is measured 30 to 60 minutes later. A serum cortisol greater than 495 nmol/liter excludes the diagnosis. C. Management. 1. Hydrocortisone 200 mg 4 should be given immediately, then 100 mg 6 hourly im or 200 mg 24 hours 4, until oral replacement is possible. Hydrocortisone orally, 20 mg in the morning and 10 mg at night. 2. Fludrocortisones to replace aldosterone: 0.05 0.1 mg daily orally. 3. To maintain NaCl daily intake to 3 to 4 grams/d. 4. Fluid resuscitation with CVP guidance. 0.9% saline is an appropriate fluid with 50% dextrose infused if hypoglycemia occurs. 5. Inotropes if hypotension persists. The choice of inotrope will depend on the clinical picture, i.e. noradrenaline if the patient has severe vasodilatation. Perioperative management of patients with Addison's disease. 1. Give all medication up to the morning of surgery. 2. 25 mg for hydrocortisone should be given at induction. 3. Small or intermediate cases should be managed as per perioperative steroids. 4. In major cases, hydrocortisone 200 mg/24 hours should be used until the patient can be weaned back onto maintenance therapy. 5. Blood glucose and electrolytes. Postoperatively. To continue hydrocortisone IV until oral maintenance dose is started. To start fludrocortisone 0.05 to 0.1 mg/d. Monitor blood glucose. Monitor daily electrolytes. Cushing syndrome clinical features. Cushing syndrome is a collection of signs and symptoms due to an excessively high plasma cortisol. The most common cause of Cushing's syndrome is treatment with glucocorticoid drugs. Anesthetists will see this syndrome in 1. Patients having pituitary or adrenal surgery to resect tumors causing a raised cortisol. 2. Patients with malignant tumors. These occasionally secrete an ACT-like hormone that causes profound Cushingoid features. Oat cell carcinoma of the lung is a common cause. 3. Patients on high-dose steroid therapy. Clinical features: moon face and truncal obesity, proximal myopathy and osteoporosis, easy bruising and fragile skin, impaired glucose tolerance, diabetes, hypertension and left ventricular hypertrophy, hyponatremia and hypokalemia, gastrointestinal reflux and sleep apnea. Diagnosis: 1. Classical clinical features are often seen but will not differentiate the various causes of a raised cortisol level. Urinary free cortisol or lack of diurnal variation will confirm a pathological cause but will not define the etiology. 2. The short dexamethasone suppression test. 1 mg of dexamethasone is given at night and a cortisol sample taken in the morning, is a sensitive test to confirm abnormally raised serum cortisol. Serum cortisol will be suppressed in the morning if the HPA axis is working normally. 3. Serum ACT levels will help determine if adrenal or pituitary pathology is the cause. 4. Very high ACT levels suggest ectopic production, for example carcinoma of the lung, and very low levels suggest adrenal hypersecretion. 5. The high-dose dexamethasone suppression test 2 mg is given 6 hourly for 48 hours and serum cortisol measured, will cause a fall in early morning and urinary free cortisol on the second day in pituitary-dependent Cushing syndrome, but not in ectopic or adrenal causes. 6. Inferior petrosal venous sinus sampling following CRH stimulation is the final confirmatory test for pituitary Cushing's syndrome. 7. MRI scan of the pituitary fossa, treatment of Cushing syndrome. 1. Selective transivoidal resection is treatment of choice for Cushing disease pituitary micro/macroadenoma. 2. Adrenalectomy uni/bilateral needed for adrenal adenoma/carcinoma. 3. PT will be medically treated prior to surgery with focus on decreasing synthesis of steroids by aminoglutamide, ketoconazole, mitotane, meteropone and cyproheptadine. 4. Spironolactone to control BP and restore electrolyte balance may be needed. 5. Insulin to control plasma glucose levels may be required. 6. All above measures count to the day of surgery. Preoperative assessment. 185% of patients are hypertensive and are often poorly controlled. 2. ECG abnormalities, high voltage QRS and inverted T waves, can make IHD difficult to exclude but will revert to normal after curative surgery. These ECG changes seem to be related to the Cushing's disease itself. 60% of patients have diabetes or impaired glucose tolerance and a sliding scale should be started before major surgery if glucose is greater than 10 millimoles. 4. Gastroesophageal reflux is common and preoperative acid suppression therapy and rapid sequence induction should be considered. 5. Venous access can be very difficult. 6. Patients can be obese and appropriately sized blood pressure cuffs, operating tables, and supports should be ordered. Intraoperatively. 1. Careful positioning of PT because of osteoporosis. 2. Despite routine monitoring, CVP is monitored as these PT tend to have higher CVP. 3. Adequate control of blood sugar. 4. We normally begin administering glucocorticoids at the start of resectioning of tumor at 100 mg of hydrocortisone hemisuccinate/phosphate IV.